Hello and welcome to this Nursing Times Clinical Practice Review. We are creating this webinar because respiratory monitoring is often poorly understood by health professionals and it's often therefore inaccurately recorded or indeed not recorded at all. And a couple of years ago on Nursing Times we published a series exploring the key aspects of respiratory monitoring. And we were actually quite taken aback by the volume of people visiting the series on the website. It's far and away our most popular series ever, and it really highlighted the need for respiratory monitoring education. So we're delighted that Hillrom has provided an unrestricted educational grant enabling us to produce this webinar. And also a free-to-access supplement which collates the series into a single document that can be downloaded from our website. And we'll give you a link to that at the end of the webinar. So many thanks to Hillrom for funding this important initiative. And I'm also delighted to welcome Wheatley, who's a respiratory nurse consultant and author of 3 of the articles in our series. And Ian's going to talk you through the key aspects of respiratory monitoring. Ian, welcome and thanks very much for agreeing to work with us on this. And before we start, the series was written a long time before we'd heard the term COVID-19. I guess since the most severely affected patients with COVID-19 have respiratory symptoms, respiratory monitoring is particularly important with this group. Is there anything specific that nurses need to know about respiratory monitoring with these patients?
Thank you for inviting me to talk today, Anne. I think that in response to your question, the COVID-19 has just showed how much more important it is to monitor respiratory rate, and also that in conjunction with saturations of oxygen with patients. But certainly respiratory rate, as patients have been shown to increase their respiratory rate with COVID-19. But also not show signs of distress whilst doing that. And obviously, patients have various degrees of ability to compensate for any sort of medical condition. Young and old patients have different responses. And it is really important that we monitor respiratory rate, as a change can signify deterioration. And certainly in COVID-19, it's been proven that it's really important to monitor it, and hence leading on to this series of articles and how important those are to read and to acknowledge.
And the oxygen saturations, there is a slightly out of the ordinary presentation, isn't there, with a lot of people with COVID-19 that I've heard referred to as happy hypoxia?
Yeah, so there's been some evidence that patients seem to tolerate low oxygen saturations, and despite that they do raise the respiratory rate, but despite that seem to be not have other problems. So they're sort of what you might call your happy hypoxics. They're lacking in oxygen, but they seem to be getting on with normal things. So yeah, it has been a strange phenomenon, but it's certainly been something that's been shown in evidence when we've seen patients come into hospital, and also in the press has also reported this issue.
So keeping track of oxygen saturation levels really important with these patients, I guess.
Certainly in the COVID-19 patients, it's been shown to be a good sign to indicate that a patient is hypoxic, and that is one of the signs of a major problem with the patient, and then also sort of determines where you're going with management with these sorts of patients. I think that the point with the patients is that respiratory rate certainly remains important. You can't depend on oxygen saturations, and in some patients oxygen saturations will remain normal, but the respiratory rate will still rise as they compensate. So certainly all the vital signs that we use should be taken into consideration and monitored closely.
Okay, thank you, Ian. I'm going to leave you to tell us all about respiratory monitoring.
Thank you. So respiratory monitoring is absolutely crucial. Respiratory rate or the number of breaths per minute is a clinical sign that represents ventilation. Ventilation, the movement of air in and out of the lungs, and a change in respiratory rate is often the first sign of deterioration as the body attempts to maintain oxygen delivery to the tissues. And failing to recognise the early signs of deterioration can result in poor outcomes for patients. Changes in vital signs, particularly respiratory rate, could help to detect respiratory failure. But studies show that increased respiratory rate can be used to help predict patients at risk of cardiac arrest, hence how important it is to monitor respiratory rate. There has been some studies that show respiratory rate above 27 breaths per minute is a better predictor of cardiac arrest within 72 hours than heart rate or blood pressure. The National Institute for Health and Care and Excellence, NICE, recommends that patients in acute hospitals should have their vital signs recorded on admission to hospital, and that a written care plan outlining which observations should be recorded and their frequency. It's really important that it's documented how frequently you should monitor a patient's observations, and that you should alter this if your patient has signs of abnormalities in their vital signs. Nevertheless, poor monitoring continues to raise concerns. Next slide, please. News 2 is based on a simple scoring system of 6 physiological parameters. And these are the standard parameters that we would use, of which are heart rate, respiratory rate, systolic blood pressure, level of consciousness, oxygen saturations, and temperature. Measuring respiratory rate is acknowledged to be a core nursing skill, yet evidence suggests there's an underreported sign and is often estimated by nurses. And why is this? Is this because the other vital signs can be monitored by a device, by a machine, and respiratory rate continues to be one of those vital signs that we need to monitor manually, although there are some electronic devices that will monitor respiratory rate. In practice, it can be quite difficult to measure respiratory rate accurately, as patients may alter their breathing if they know they're being watched. So do we go for a sort of covert respiratory rate monitoring? Well, there are subtle ways of monitoring respiratory rate without making it too obvious, and I'll come to those later in the talk. Whilst there's an accepted definition for normal pulse and generally blood pressure, there's a sort of variety of ranges really for respiratory rate. But we're normally saying a normal range is between 12 and 20 breaths per minute. The normal accepted range of 12 to 20 breaths per minute is mentioned by the RCP and the Royal College, the Cardiac UK 2015. However, this can vary according to the patient's age and medical conditions. It's generally accepted that respiratory rates at higher than 25 breaths per minute and all those less than 8 breaths per minute show signs of abnormality, possible deterioration. So it's fundamental to assess a patient and to do the respiratory rate. It's fundamental to acknowledge a baseline, determine the patient's usual range for the respiratory rate. It provides great assistance in identifying deterioration or improvement in a patient's condition, and it can help to determine the level of care required for your patient, and that's why all the vital signs should be done. Vital signs should be monitored at least every 12 hours, unless specified otherwise, and generally it's because a patient's had another problem, whether that's surgery, or they come with a chest infection, and you've had an alteration in the frequency of the vital signs. Vital signs are recorded on admission, as said, documented clearly, and you should consider them as part of a holistic assessment. So you're not looking at one sign as a change. You should look at all the vital signs and determine whether there's any abnormalities that need a response to. And they should form part of an early warning scoring system. Nurses need to be aware a small change in a patient's normal respiratory rate of 3 to 5 breaths per minute could be an early sign of deterioration. Should also note that the pulse oximetry measures saturations of oxygen and not ventilation. So someone can have relatively normal saturations but a raised respiratory rate and not essentially improving their tidal volume or getting the carbon dioxide out. So it's really important to monitor respiratory rate. Next slide. Breathing itself has two essential components. Move on to the next slide, please. Ventilation, the process of physically moving air in and out of the lungs. And gas exchange, the process of getting oxygen into the body and carbon dioxide out of the body. The lungs themselves are situated within the rib cage, enclosed by two pleural membranes. And at the base of the thorax, separating from the abdominal cavity, lies the diaphragm. This is the main muscle of inspiration and is innervated by the phrenic nerve. The lungs are made up of large and small airways, the trachea being the largest and first of the 23 generations of airways. Alveoli are the main site where gas exchange takes place. This allows for a large surface area for gas exchange. And you have central peripheral chemoreceptors, which are sensitive to hypoxia, that's low oxygen levels, and hypercapnia, the increased carbon dioxide levels, and control the drive to breathe. Air naturally moves from an area of high pressure to an area of low pressure during normal breathing. Inspiration occurs by the contraction and the flattening of the diaphragm, and the contraction of the external intercostal muscles, and this causes a rise and outward movement of the rib cage. This increases the size of the thoracic cavity, and these changes cause the parietal pleural layer of the lungs to move with the rib cage and diaphragm, creating a negative pressure, and the visceral pleural layer attached to the surface of the lungs follows. The lungs expand, drawing air in. Expiration at rest is largely passive process, and inspiratory muscles relax the elastic recoil of the lungs, giving rise to a state of pressure equilibrium before the next cycle. Of course, respiratory rate associated with exercise and anxiety may be greater than 25 breaths per minute, and that's obviously abnormal, but normal at that time. And that will normally return to normal in a resting state. So you really have to take in consideration the patient at that time and what they're doing. For gas exchange, gas moves from an area of high concentration to an area of low concentration, and the partial pressure of oxygen in the atmosphere is higher relative to that of the body and the bloodstream, and contains a higher partial pressure of carbon dioxide than the atmosphere. For effective gas exchange to take place, air breathed into the lungs must travel to the alveoli membrane, where the capillary walls are really thin and there is overall large surface area. When ventilation and gas exchange occur, the normal range of oxygen saturations of the blood are generally around 94 to 98%. And this is maintained fairly well at rest, with a normal respiratory rate between 12 and 20 breaths per minute. However, in some lung conditions where gas exchange and or ventilation is impaired at rest, the hypoxic and hypercapnic drives would increase the respiratory rate to maintain saturations. Poor gas exchange, as seen in conditions such as pulmonary fibrosis or emphysema, caused by a thickening of the alveoli wall and destruction of the lung tissue, respectively, results in a higher resting respiratory rate. It's therefore important to consider patients' normal baseline. Common obstructive lung conditions such as chronic obstructive pulmonary disease or COPD or asthma are characterised by an increased resistance to airflow as the small airways are narrowed and reduced oxygen delivery to the alveoli. During acute exacerbations, this resistance is increased, leading to a rise in respiratory rate. And bronchodilators normally help to relax the smooth muscle and therefore reduce resistance and hopefully return respiratory rate to normal levels and get oxygen into the system. There are other conditions such as neuromuscular conditions which affect the lungs, often lead to underbreathing, hypoventilation, as mechanisms needed for normal ventilation do not function properly. For example, poor diaphragmatic function, weak intercostal muscles. In these cases, sometimes you find that the patient has changes in their oxygen levels and also change in their respiratory rate. Again, other conditions, so patients that have had surgery and during post-operative recovery where they've had certain medications that can reduce the respiratory drive, can affect the respiratory rate of the patient. So it's really important to closely monitor patients post-operatively or any patients who are on any type of analgesia, especially those that affect the central respiratory drive. Again, I must advise you to remember that pulse oximetry measures oxygen saturations, whilst the respiratory rate measures ventilation. But for respiratory rate to be a useful tool as an early warning sign in patients, we need to know what is normal for that patient. So hence it is really important to do observations of a patient or vital signs of a patient when they're first admitted, so you can determine what is normal and what is abnormal for that patient. Changes in respiratory rate occur automatically in response to a physiological demand, but it's possible to consciously increase or decrease respiratory rate for short periods. Next slide, please. There are some key indications for measuring respiratory rate, and I'm also going to go through the accurate measurement of respiratory rate before going through the key indicators. So really, and I'm not sure if this is realistic, but you should ask the patient to rest for 20 minutes prior to measurement. And I know that sometimes that can be quite a challenge, but if your patient is on bed rest, that should be easier. Patient sat in a chair, make sure they haven't recently exercised. Make sure that if you're doing home visits, that they haven't just gone up to the front door and answered the door and walked back to their chair. So get them to have a period of rest so that when you monitor them, hopefully you're going to get their baseline respiratory rate rather than their exercise respiratory rate. Normal infection control procedures apply. Gain your patient's consent. Obviously, you're trying to measure respiratory rate fairly covertly, so maybe you will do this as part of their other vital signs, pulse rate, blood pressure, etc. Ensure the patient is comfortable. Patient with pain will obviously have a slightly higher respiratory rate. Make sure that if they're on oxygen, that oxygen is delivered as required. When you look at your patient, physically determine whether they're using other muscles in their chest, shoulders, or neck to breathe. Can they talk to you in full sentences, or are they using single word answers, or indeed not being able to speak at all? Whilst you're talking to them, you can check the patient's cognitive status. Can they answer simple questions, date of birth, where they are? So like I said, use a covert technique, so maybe take their pulse whilst you monitor the respiratory rate. Count the chest movement for a full minute. And whilst you're doing that, note the respiratory rhythm. You can look at the depth, how much expansion the patient's got. Is their tummy moving with their chest, or is it going the other way? Look Look at the patient's pallor, look at their colour. And make sure you record the observations in the patient's notes on the observation chart. And when you've finished the observations, perform hand hygiene. So what are the key measures for respiratory rate and what should they include? Well, we should consider things like post-operative monitoring. Certainly if patients had analgesia or still on analgesia, maybe a sliding scale painkiller. If we look at things like a patient with complications with pulmonary edema, if a patient's had a recent blood transfusion or any other sort of fluids, IV fluids, which may lead to some overloading, which in turn increases the respiratory rate. Respiratory rate is really useful for identifying patients who are deteriorating and are critically ill. So we should still continue to monitor those patients to determine if respiratory rate is going up or going down, come back down to the baseline. We can monitor respiratory rate to see if treatment's working. So, for example, a patient who is in pain, has a raised respiratory rate, and then you give them some analgesia, does the respiratory rate come back down to a normal level? We can also use it when we're monitoring chronic lung disease. And obviously you have to determine what their normal rate would be and get them when they're well. And then when they do exacerbate, you can determine the response to treatment. We should also monitor patients who have oxygen therapy and monitor the respiratory rate. Next slide, please. So there are a number of causes of abnormal respiratory rate. We all know that presenting can be quite stressful. So anxiety-driven can increase your respiratory rate. So a patient with anxiety would have a raised respiratory rate, otherwise known as tachypnea. Emotional distress can increase respiratory rate. And I've mentioned pain previously, that can also increase respiratory rate. Raised temperature, the body's physiological response, increases respiratory rate. Exercise, you go for a run, there's more oxygen demand, you get rid of lactic acid, you increase your respiratory rate. Asthmatics, with their narrowing of their airways, increase their respiratory rate to get the oxygen and get the carbon dioxide out. Pulmonary embolus, pneumonia. When you've got a chest infection, you're trying to fight the infection, so not only fighting the infection, but sometimes pneumonia is in one area of the lung, and you increase the respiratory rate to compensate for the reduced capacity for the oxygen in that area. Acute respiratory distress syndrome. Anaphylaxis. You get your bee sting, you have your response to that, histamine release, and the respiratory rate goes up. Not only that, but the anxiety caused by being stung. Heart failure, so the accumulation of fluid in the lungs means that you struggle to get the oxygen in, and therefore you increase your respiratory rate. Shock, so reduction in fluid, you have to drive what you have got in the body around the body, and at the same time you increase your respiratory rate. Patients with diabetic ketoacidosis, so to remove acid from the body, we increase our rate to remove carbon dioxide, so hence that is a really good sign. Neuromuscular disorders, so patients with motor neuron disease and other neuromuscular problems where they get weakness of the chest muscles, the diaphragm, can be indicated by increasing respiratory rate. And chronic obstructive pulmonary disease, as I mentioned earlier. And then if we look at things that can slow down the respiratory rate, so bradyapnea, so depression of the respiratory centres, often that can be due to some sort of medication. Sometimes it can be due to neurological insult, increased intracranial pressure, diabetic coma, exhaustion caused by severe airway obstruction, and sleep apnea, patients who pause for breath for more than 10-second periods at a time, who indicate that their respiratory rate is lower because they have an obstruction in their upper airway, usually the tongue falling back and meeting the soft palate, and they have a reduced respiratory rate, usually noticed by their partner, and the patient wakes up gasping, and then they get quite stressed and and they pant for a while and then they go back to sleep, and they have a duration of a very slow respiratory rate. And obviously hyperventilation syndrome. So again, often goes hand to hand with obstructive sleep apnea, but not always the case. So a reduced ability to breathe deeply and to get the oxygen in, usually by the patient being compromised by their abdominal size, and sometimes by the mass around the neck as well. So measurement of respiratory rate is part of the Resuscitation Council UK ABCDE assessment and process. And this approach helps to form a picture and detect impending adverse events in conjunction with the National Early Warning Scoring System, or NEWS2. And the NEWS2 sets the normal range, as was mentioned earlier, for adults between 12 and 20 breaths per minute. As we mentioned earlier, respiratory rate varies with age, and in some older people they have a higher baseline respiratory rate, which may be partly be due to deconditioning. Next slide, please. Tachypnea itself can be defined in this group, in the older age group that is, as above 28. Some studies have defined, and this increases due to age-related changes that affect the body and ability to meet physiological demands. So the table 1 that's up at the moment shows the normal range of respiratory rate between 12 and 20 breaths per minute. Then if you look at the normal range for above 65-year-olds, it shows a range between 12 and 25 breaths per minute, and this is from a study. Again, the rate goes up, a normal range in the above 80s, 10 to 30 breaths per minute. And then we look at bradypnea, generally indicated at respiratory rate of less than 12 breaths per minute, and tachypnea above 20. So respiratory rate should be monitored, and monitoring should be increased if the patient shows signs of deterioration. And as I mentioned earlier, respiratory rate above 27 breaths per minute can be a key predictor of cardiac arrest. And conversely, a respiratory rate of less than 12 breaths per minute, or bradypnea, is also a concern and should alert the health professional to consider causes. Now, in many instances, we use technology as part of our tool to look at vital signs, and respiratory rate may be monitored using things like impedance pneumography, which measures electrical activity in the chest during inhalation and exhalation. However, there are limitations to electronic monitoring in this way. You know, cables come off, the sticky dots come off, the monitoring device malfunctions. There are other measures that you could use, capnography, which is probably more accurate. It's not generally available in normal ward areas, usually in more critical care areas. And you do find with some electronic monitoring devices that you can get with alarm fatigue. So a patient who's talking, who is more active, may increase their respiratory rate, and their alarm goes off, and alarms may not be monitored regularly because they're going off so frequently. So the observation of that is something that people take for granted. So you have to consider whether electronic monitoring is important, and it certainly has a use, but there's nothing better than looking at the patient and eyeballing them and just checking that things are okay. So the procedure, I think we've mentioned that earlier in regards to monitoring respiratory rate. So we should make sure we use good infection control procedures, wash our hands, gain the patient's consent, make sure your patient's comfortable, make sure that if they have oxygen, it's prescribed for one thing, and they're actually using it, and the oxygen mask isn't dangling around their neck rather than on their face. Make sure your patients have time to rest, observe their respiratory function, not in isolation of the respiratory rate and monitoring for 60 seconds, but observe the full respiratory function, the rhythm, depth, etc. Note whether the patient's alert. Are they talking to you? Are they making sense? Use a watch with a second hand. If, like me, you can't wear your watch at work, hopefully you've got a clock on the wall, and then you better monitor from there. Monitor other things as well. What colour is the patient? What's the pallor like? What do the lips look like? Are there signs of cyanosis? Check for signs of hypoxia, and use the pulse oximetry tool if it's available. Make sure you record your observations. So I mentioned earlier, not just the respiratory rate, but other parts of the breathing rhythm and the chest movement. So in normal breathing, a fairly steady rate in respiratory volume and depth of chest movement are maintained with equal expansion and symmetry. But when there is an increased demand on the respiratory system from an acute episode, such as chest infection or long-term conditions, such as chronic obstructive pulmonary disease, the respiratory rhythm and chest movements may change. So figure 1 here shows that on inhalation, your chest expands, your diaphragm contracts, your intercostal muscles contract, and the chest moves out. The visceral and parietal pleural layers separate, and you draw air in. On exhalation, it's more of a passive event, and the chest contracts, diaphragm relaxes, and you breathe out. Next slide, please. So the changes in demand on the body are generally due to compensatory mechanisms as a direct result of a chemical imbalance. And the primary cause may be mechanical, metabolic, or neurological. Changes result in an increase or decrease in respiratory rate, depth of breathing, and the pattern of breathing. And changes in rhythm and chest movement are made through feedback mechanisms to the central respiratory control centers of the brain. And there's a range of receptors that provide information that is interpreted in the higher respiratory centers. And they modulate the respiratory rate and the chest movements. And these centers, receptors, are peripheral chemoreceptors found in the carotid arteries, detecting changes in PaO2 in the blood and PaCO2 and pH. The central chemoreceptors in the ventral medullary surface of medulla oblongata in the brain, and they detect pH changes. The mechanoreceptors, which are stretch receptors located in smooth muscle of the main airways and parenchyma. And they respond to excessive stretching of the lung during inspiration and send signals to the apneustic center of the pons located in the brainstem. And the pons controls inspiration and expiration. So in relaxed normal breathing, the respiratory rate of 12 to 20 breaths per minute, the chest expansion on inspiration should be the same or similar on each breath. Chest wall is generally symmetrical. Accessory, that's neck and shoulder muscles, are not generally used. And diaphragm muscles are functioning. There's no paradoxical movement. And that means that the chest and the abdomen moves in the same direction on inspiration and expiration. Paradoxical movement, as shown by figure 1, shows that A is normal, so the same direction of travel for the chest and the abdomen. And in patients who have got, say, a neuromuscular disorder where they've got a weakened diaphragm, you may see the abdominal muscles move in a different direction to the chest, and this is abnormal. And abnormality in respiratory rhythm may be related to changes in the patient's metabolic state. For example, a patient with diabetic ketoacidosis who may exhibit signs of rapid, deep breaths, otherwise known as Kussmaul's breathing. And this is in place to aim to reduce the level of carbon dioxide in the blood and to maintain a normal pH and re-establish the homeostatic state. The key principles of chest observation are that it is really important to have a clear view of the patient's chest. So the chest area should be exposed if possible, obviously protecting the patient's dignity by screening the bed area. So look at your patient, look at the chest symmetry, stand in front of and facing the patient. Observe whether the movement of both sides of the anterior chest is symmetrical. Chest abdominal movement. The chest abdomen should move in the same direction as mentioned earlier. It's difficult to observe this. So position the patient in the semi-recumbent position and observe the movement from the side gives the best view. Look at the depth of the chest movement. In normal tidal breathing, inspiratory-expiratory movement is fairly constant. Monitor for a raised respiratory rate above 25 or a low respiratory rate, so less than 12. And assess whether the tidal breathing is very deep or it's very shallow. Look at accessory muscle use. We know that some of our COPD patients, they use their shoulders, they breathe really deeply, they use their neck muscles, and they do work really hard, especially in exacerbations. They lean forward over the table and rest their arms to try and get air in. Observe the patient from the front and note where there is increased work of breathing at rest, which includes the use of the sternocleidomastoid muscles of the neck, the scalene, the shoulders, pectoral and abdominal muscles. As I said, the patient may sit forward with the hands on the knees at rest or resting on the table to relieve the respiratory muscles and increase their respiratory inspiratory capacity. Monitor the rhythm. So, like I said, breathing rhythm is usually constant and regular. That rhythm with abnormal long pauses between breaths and cessation of breaths, and then rapid breathing is abnormal. And table 1 sort of illustrates some of the abnormal breathing patterns from a normal breathing pattern to an increased respiratory rate, bradypnea, decreased respiratory rate, apnea, absence of breathing, hypopnea, increased depth and rate of breathing, Cheyne-Stokes, the gradual increases and decreases in respirations with periods of apnea, Biot's abnormal breathing pattern with groups or clusters of rapid respirations, equal depth and regular apnea periods. Kussmaul's, as mentioned with the diabetic patients, tachypnea and hypopnea, and apnestic, a prolonged inspiratory phase with a prolonged expiratory phase. Next slide, please. So respiratory rate is a really good tool that adapts really quickly to changes and to the demands placed on it. So monitoring it is useful to determine whether the patient is deteriorating. However, it is really uncommon for a significant disturbance to occur in isolation as a single physiological parameter. So it's important to do the patient's vital signs completely. So assess multiple parameters and monitor the trends. Hence why using something like the NEWS 2 scoring system, which uses the 6 physiological parameters: respiratory rate, oxygen saturations, systolic blood pressure, pulse rate, level of consciousness, and temperature, are a really useful tool to determine whether a patient is deteriorating. I'm going to take you through a patient case study. Next slide, please. The patient is an 80-year-old and has come into primary care. They've got a 5-day history of a productive cough. They're short of breath, and they've got rapid breathing. They've got some chest discomfort on deep breathing, and they've got a fever. This patient's got a medical history, which is just really hypertension, arthritis, and they are an ex-smoker. Social history: so the patient lives with his wife, they live in a bungalow, there's no recent travel. And the impression is the patient possibly has community-acquired pneumonia. The baseline vital signs show a respiratory rate of 22, so a little bit above the normal range, but not excessive. They have a shallow depth and regular breathing pattern, and the saturation is 93% on room air. The vital signs should be recorded as part of a holistic assessment, and this gives your baseline measurements to determine whether later that there's any changes, whether you've given some treatment and they've improved, or that they've got worse. And respiratory rate should be measured over the full 60 seconds. And like we said, the depth of his breath was shallow, but the rhythm was regular. And his oxygen saturations were 93%. He was, however, sitting on a chair, leaning slightly forwards, with his hands on his knees, and reports that he's got some chest discomfort on the right side. His chest movement appears symmetrical. There's no paradoxical movement, and they were moving in the same direction. So it's quite difficult to distinguish between something like pneumonia from a chest infection without a chest X-ray. However, it has been shown that simple blood tests like a C-reactive protein may show inflammatory responses, and that if a patient is in primary care, the GP surgery may help to facilitate management of this patient. Indeed, another tool, sometimes called the CRB65 tool, CRB65 tool, where you look at confusion, respiratory rate, blood pressure, and age of the patient, can help to give you a figurative tool to determine how you should treat this patient and whether they need secondary care rather than primary care support. In this patient's case, after 4 hours, he showed an increase in his respiratory rate and indeed in his heart rate. The chest movement was asymmetrical and reduced on the right side, and he was using its accessory muscles, and a new score of 8. So sometimes anaerobic respiration occurs when there's inadequate oxygen supply to the tissues, and Mr. Carberry's oxygen levels in this case had decreased to 91% on room air. His chest movement was asymmetrical, reduced movement on the right side, and again he was answering questions in short sentences. He was using his accessory muscles to help relieve his respiratory muscles and increase inspiratory capacity. These changes in his vital signs indicated that Mr. Carberry was starting to meet the high risk criteria, scoring 8. And the treatment options for this patient include antibiotics and oxygen to maintain saturations above 92%, as well as needing an admission to hospital. This patient potentially had sepsis, which is an overreaction of the body's immune system in response to infection. Patients requiring increasing oxygen demand, so increasing oxygen levels, is really important for those patients to be monitored closely, to increase the frequency of their observations, to monitor respiratory rate, and to monitor their saturation levels. This particular patient had admission to hospital, at which point his respiratory rate was up to 30 breaths per minute with his reduced saturation level. And an X-ray showed that he had some shadowing on the right lower section of his lungs and that he deteriorated. So the case study illustrates how respiratory rate is an early predictor of deterioration. It remains one of the vital signs that's often poorly assessed, and intermittent measurement of respiratory rate means that vital changes may be missed. And that draws to the close the last case study and the respiratory rate monitoring. Thank you. Is there any questions for me in regards to the respiratory rate system?
We did actually have one question that has been sent in, if you just bear with me. I have to say, one of the things that affects respiratory rate is listening to someone talk about respiratory rate. Mine's been going up and down all the time. But yes, we had a question over Twitter, actually. Is there any evidence on how fast the respiratory rate increases after exposure to infection?
Yeah, so I think that's really difficult to answer because patients come in all shapes and sizes and all different degrees of condition. So someone who's fit and healthy and fairly young who had an infection would compensate for a fairly reasonable period of time and probably increase their depth of breathing. Although they may have changes in the respiratory rate, they may be able to manage that much more effectively than someone that was maybe older, deconditioned, had an underlying lung disease. So I don't think there is a sort of time. You couldn't say, you know, we should monitor this patient this frequently because they've got an infection this type and their respiratory rate is going to go up like this. There's so many different factors to consider for patients that it's really important to assess a patient's respiratory rate, get the baseline, and then make sure that you reassess them to determine whether that's changed or not. And often it's not just the respiratory rate that you notice, but things like the change in the patient's ability to be able to talk in sentences, and they are now talking in short sentences, and it's going to one-word answers. The patient's muscle strength and their ability to function as they change position frequently, or do they sit up and they're trying to take deeper breaths. You know, what's changed with them? What have you noticed? Has their colour of the skin changed? That generally you look at a patient more holistically, and respiratory rate is a really important vital sign to monitor, but you should look at the whole patient, and don't always depend on the electronic monitoring. As we know, probably if you took my blood pressure now, it'd be really high, and probably my heart rate too, but I'm sure that returns to normal quite quickly. So you have to take into consideration the circumstances. So I think it'd be difficult to put time on how quick things change with respiratory rate. It's one of the quicker vital signs that changes, but it does very much depend on the patient's condition and age, so that should be considered as well.
That's great. That's great. Thank you very much, Ian. And thank you also to Hillrom again for providing the educational grant, enabling us to produce this webinar and also the supplement, which you can download from nursingtimes.net/respiratory.